Phones off, cameras off. All right, secret modes of communication. Oh yeah, not a problem. Good morning.
Good morning.
And here we are at another session of what I call the Wisdom Warriors. Those are the support group that have been through just about all of it and have unique and very learned insights into many of the things that people out there are going through or will be going through. And I want to thank Manor Care for offering us their executive conference room, as it were, for the opportunity to let us meet every other Wednesday. So thank you, Manor Care. 2 weeks ago when we met, and I'm not going to try and replicate it at the moment, but we had a very interesting discussion amongst those assembled, and many of you were here, about the concept of emotional divorce, because it had been on the show, the radio hour, the day before and the week before, with a bioethicist by the name of Vicki Kind, who had been discussing it and then put it out to her network and picked up a firestorm over it, because most of the people that follow her are much younger, and it got into a whole issue of vows and honoring your marriage vows, etc. However, we were really casting it in light of dementia. And the comment that came back, because a week ago I had on Barry Sinrod, who you may or may not remember was on very early on. He's the gentleman whose wife has a very advanced Parkinson's. They really don't expect it to go more than another 4 or 5 days now, but he was on a 6 or 8 month crusade to try and figure out how he could get what he felt was his advanced directives honored, so that somebody could, in a proper manner, call it assisted suicide, for lack of a better word. But he ran right up against the medical, legal, and the ethical system in saying we can't do anything to hasten that, and that we as a country really are not very prepared to do things like that, even though we have a couple of states out west, like Washington State and Oregon, that are exploring this concept. But I want to leave it for a different day, because I find that if we try and replicate what we talked about last week, excuse me, it'll never come out the same way.
You didn't mention that.
You never said that it was lost. That
Yeah.
the tape was compromised.
Oh, and also the tape was compromised. Had nothing to do with me, and but it did happen, and so that's why we at some point in the future may want to replicate that, because I found on the air it certainly engendered a lot of reaction. And I personally feel, and what this table had determined, the group had determined last time, while it may not be something that everybody subscribes to for themselves personally, there wasn't anybody here that felt that it was not something that they could easily see another in that position doing, without having any resentment or ill feelings, or thinking that it was improper or out of place. So with that thought in mind, it's part of a future conversation. One of the things, and Irene, we may want to pick up the conversation from where you were without getting into too much detail. But your husband is in a facility, and he does have dementia, as well as other physical complications. And you were recently notified that the facility felt that possibly he should move from one section to another. In this case, they have cottages, because they felt possibly he might be declining in capability. And you came in this morning and said that you were distressed over that, as would be anyone in your position. And I'd like to kind of pick the conversation up from there, because I thought it was a very good one that we kind of had in before the cameras went on, and not necessarily directed at you per se, even though you raised the subject. But we have a number of people here that have been through that and are going through that. And you were unsure whether or not your husband's recognition of the change would upset him, and many here volunteered that it was probably more your recognition of the change that was difficult. All right, Roberta, what's your feeling on that?
I remember when Jerry went into the first placement, we didn't have space where he finally ended up behind here. We had to place him in another facility up in West Palm, which is a number of miles away. And when he was then moved down here, he didn't know the difference. He knew there was something different because it was a different room. He kept wanting to go to the original room because the place looked the same. I found that the staff knew what they were doing. They told me to stay away for a couple of days. They got him acclimated. And then I came back and he was doing fine, and as fine as he would ever do. And he just acclimated to the new place as if it was the old one. Something with that disease just does not let them realize that they're making all these changes. When he changed from here to there, he had been in rehab and went over to the other place. The acclimation was very easy from physical rehab into a dementia facility. And I saw it happen with everybody, with other people who came in. If the spouse or the caregiver or the advocate, whatever we're going to call them today, doesn't upset the apple cart, the staff can acclimate the patient, the client, the individual. Residents, the word I'm looking. Thank you, David. And at that point, you come back in and you advocate, make sure where they are, they get the best that they're getting, the same as you're doing today. And sorry he's not here anymore, but he stayed for a year like that and it was fine.
When are they making the move?
Well, I told them that Friday I will be there with my daughter and we want to really meet the afternoon nurses, because I went and I met the morning already and she wants to go with me. So I guess anytime after Friday.
All right. Question?
No,
Oh,
comment.
say-
My husband's in the same facility as Irene's, and he started in cottage number 3. They go by level. And after several months, he became incontinent, and he couldn't stay in that cottage because they knew the difference there. They were a little bit higher functioning, and they moved him from cottage 3 to cottage 5, where her husband is now. And he didn't know the difference. He just went in there, everything looks the same.
Mm-hmm.
And it's all laid out the same, and it bothered me, as I told her, it bothered me a lot more than it bothered him. Because I don't know if you can say levels, because they're all so low that it really doesn't make much difference.
Okay, so it's more a symbolic change of
Yeah,
proof
yeah.
than it was an acknowledgement.
Yeah, he didn't know the difference, he was perfectly, he went from a double bed to a single bed. I said, does the bed bother you? He said, no.
You know, one of the questions I would ask, and we're always very candid, if he were still, quote, and interpret this any way you wish, higher functioning, all right, but still had incontinence, would that be a reason to move him? I mean, when you take a look at the world out there today, there are so many of us who you wouldn't know whether or not you're wearing, you know,
Depends.
whether you have, right, whether you
I don't
have
know.
incontinence or you don't. Was that a reason to move him?
No, I think the whole thing was, I could see in the cottage he originally was in, they were all speaking, and he's nonverbal.
Okay.
He doesn't say a word, like they said. He doesn't say anything. He doesn't talk to us. He doesn't have the capacity to talk. That's the first thing that happened to him when he got Alzheimer's, is he seemed to lose the ability to communicate. He can say yes, he can say no. And the only thing I find now is that when I go in, he has a big smile on his face when he sees me. So he must recognize me, because he can be sleeping and I'll tap him on the shoulder and he looks up and there's a smile.
That's
That's
nice.
nice.
So there is some recognition, but other than that, when I go to visit him, I sit there. There's no communication. I have a couple of puzzles that I do with him.
Mm-hmm.
I more or less place the pieces and he pushes them in. But other than that, there's very little communication.
So it doesn't matter which cottage?
It doesn't really
I have,
matter.
Go ahead, Robin.
I think
and I may be putting words into your mouth, it seems to me that this move is to Irene saying he is declining. And that's a very difficult thing to handle. We know it's not gonna get better, but we don't like to see the decline. And I think maybe that's more important than the fact that he's gonna be in this cottage or that cottage, because as you said to me last night, the new cottage has only 8 people. He'll get 2 to 8?
Yeah.
So he'll get a whole lot more attention,
Right.
probably better care. And yet, I think it's just because we see that this is getting worse. And sad to say, it's gonna get worse.
It's
What
apparently
before?
something, it seems to me it's apparent that you're the person that has to cope with it. You are the one. He's gonna be perfectly fine where he is. We have to give them the benefit of of knowing where to put him, when to put him, where they put him. But you're the one who has to cope with it. And it's always been more difficult for the caregiver to cope.
Yeah.
That's the problem. And right now, you're a perfect example of what I'm saying. Because you're dabbing at your tears, and I can understand it. I wish you didn't have to. I know,
Yeah, that's-
I know.
it's
But
okay.
after a while, you'll be, I hate to say get used to it, but you'll accept the fact that he is deteriorating, which everybody knows happens.
You know, when I look at the new cottage, and I did see it, the people in there, Mel's young, he's only 71,
Right?
and the people in there looked to me so old and like this, and, you know, and so old.
They're ill, they're all ill.
I know.
I know you know, but unfortunately, you got to cope with it, Irene, you do.
I know.
And what I had said last night on the phone, yesterday afternoon rather, was you know that Alzheimer's is a fatal disease and that it is progressive. And we've all heard stories from people here who've lost spouses or they've gone to a much less functioning level. And yet, when it happens to you, it's personal.
And you know something, I mean, I know how you're feeling, it's horrible. The patient, or the resident, my husband didn't have Alzheimer's, he may have had a touch of dementia, but he was ill. And he was in the hospital this last time for 6 months. He went from the hospital to rehab, back to intensive care, back to rehab. Didn't make a difference in where he was. And if you had known him 6 months before then, he was so dynamic and so full of life and so active, but he was in a weakened condition. Didn't make a difference. I mean, your husband has a different situation, but a patient, I mean, can you imagine any of us living for 6 months in a hospital? You'd say, get me out of here. But he was too weak to think that. And so we have to put ourselves in the patient's place also. They're not fighting to get out, they're not fighting for where they live. We are fighting for them.
Irene, you're going through now what you did when he first went into this place.
Exactly.
You're
Start all
reliving
over
it
again.
all
Exactly.
over again, and you
Exactly.
made it. You came through it, you accepted it, and you were doing fine. Unfortunately, you have to repeat it.
And
How
that,
much
I
more
think
is-
that was your opening comment before the camera went on. I feel like it's starting all over
That's correct.
again.
That's what you said.
You know, one of the things, and I'm thinking about the meeting Friday when your daughter comes down, is that when we go into facilities like this, since, I mean, you're familiar with it, your daughter has certainly seen her father in that kind of a setting for a while, but it's very, very difficult for people on the outside, even if it's family, to walk into settings like that and either imagine Dad the way he used to be, or saying to themselves, I couldn't do this. This is not, you know, this is not a place, quote, I could stay. And I see that many times when families come down to look at assisted living or to try and do a nursing home placement. They go with the idea that how would they live there? And yet they are not the patient or the potential resident, and we forget that the only reason that we're doing it is because we can't keep them at home, either because of disruptive behavior, or it's beyond our capacity to handle it in a safe and sound manner, and that they would do better in a professional setting. But I think the recognition, as everybody has said, that he has taken another step. He does not recognize that the people in the room are older, younger, in that regard. No, because with a cognitive decline, the ability to put it in perspective and think about it, oh, I've moved into a new place and those people look older than me, even though I may not have looked in a mirror for a long time to know how I look. But he is really one of them. Maybe not yet in your eyes, but from a functional level, from an ability to be part of the group, your non-recognition, shall we say, that he was ready to make that move, but that the staff and management were, kind of makes it something that was taken a little bit out of your hands, because you made the comment, you're happy with the facility. You may not be happy internally with what this move signifies to you, and I think that's perfectly understandable. But I have a feeling a couple of weeks down the road, when he's fully acclimated and you're used to going to 5 instead of 3 or whatever, you know, whatever it is, that as long as you see that things are being done properly, that you as the advocate, that you as the spouse are seeing that there really isn't a big difference in terms of how he's being treated, but that he fits in more readily with the group that he's with, I think you'll get some comfort out of that to the degree that one can.
Irene, excuse me, I just wanted to say, one thing should give you relief to know how astute his staff is, that they are doing their job. And you may not have wanted to see it, but they recognize it to the point where they hope to do more for him. And that should make you feel better, rather than his being neglected.
Well said.
Yes.
On
Mary?
a slightly alternative but similar vein, my husband, as you guys know, does not have Alzheimer's, but he has some dementia. And he has physical problems, he can't walk, he's in a wheelchair. On Memorial Day, I thought I would do him a good deed, rather than seeing him just for lunch and maybe a shopping trip, because he's a shopaholic. I made arrangements to have him for the whole day, for lunch, and then in the afternoon I took him to the pool, and he laid on the lounge while I played some Romeo, and then we went back to the house. He couldn't nap, he rested a little, and then we went out to dinner. He was exhausted. It was too much for him. I thought that I would, be making him happy by keeping him longer than usual, but in retrospect, it's the same thing. It was my point of view, but for him, 3 or 4 hours of a
Right,
visit.
because
Too much.
in his normal setting, in the wheelchair or whatever, he may fit very well, but we don't realize how deconditioned one gets when you're not up walking around, building stamina, having more exercise. So you were right, you were doing it as a good deed, but you didn't really stop to think about, and next time you will, whether or not he was capable of enjoying it at the same level that you hoped he would, and that you obviously did. And I think that just shows the juxtaposition of whose set of eyes are we viewing the resident patient loved one through.
You know, when I
Time to
first
learn
put him
that.
in there, one of the things I liked about the place is that they told me that there are these different,
Levels.
levels, and they don't put everyone together.
Mhm.
They separate them,
That's good.
which I thought at that time was wonderful, but now I changed my mind.
But now you have to think at this time.
Yeah, well-
He has progressed or regressed, or call it what you will, that they feel that he should be
And
in
they're
a.
putting him in level 1, which is the lowest level.
That may very well be, but you have to give them
But maybe
the credit.
he'll thrive to the extent
That's what
that
they
he
say.
can there. And I think that's the perspective, even though it's hard for you to internalize that because it's a recognition that the disease is progressing, but yet it needs to be a recognition also that he's in a more suitable setting for his condition based upon what the professionals say. And I think there are times when our perspective versus that, I mean, how many times have we gone to the doctor says you need to do this, and we say, well, I don't think so. But we're cognitive, we're competent, we can weigh our choices. In this particular case, he didn't, and you were professionally advised. My only concern is that when your daughter comes down, much as she is a member of the family, that maybe the night before she gets here, a conversation similar to the one that we're having needs to go on between the two of you so that she is a little more participatory in understanding why this is happening and not just to view it totally as Dad's not doing better, and maybe if I keep him in 3 or 5 or 7, whatever it is, it'll make a difference. If that were the case, if there was some kind of magic smoke that was happening in cottage 5 that would enhance the condition, well then yeah, keep him there. But I don't think that the cottage number per se it has any great reflection on what's needed for your husband.
Yeah, I think that my daughters are more accepting than I am.
Okay,
That's good.
I think they are.
Robin?
You know, you mentioned something about an outsider coming in and seeing where they're living, and my brother-in-law came up, the third time he's seen him in a year and a half. He came up from Miami, and
Is Alan's brother?
and said, I could never live like this.
No.
Neither could Alan.
And,
Right.
Neither could
and
Alan.
his thing is, and his wife's mother died of Lou Gehrig's disease. And, so they're discussing suicide rather than going into a nursing home or living with that kind of, which is really sad. But you mentioned that he couldn't live like that, and yet it really is, you know, he said it's nice, it doesn't smell, it's clean, you know.
Right, but it's not his picture
of what he wants.
himself should that happen. And, you know, one of the conversations that we had last night on the radio show, because this popped up because I saw Barry on Sunday, we had dinner together, and we communicate, it's keeping me, you know, kind of informed as to what the progress of things is. But we made the comment, and we've discussed this at times in the past, but I think it's relevant to hear right now. We can have a pet who all of a sudden gets sick, all right, has cancer, and we don't turn around and say, okay, now we have to, if it's not appropriate, all right, now we have to operate, now we have to put him in the doggy nursing home, and now we have to wait for nature to take its course. We have the ability to say, I don't want to see that happen. And with the vet's concurrence that the dog is in that, or cat or whatever, you know, I'm not picking on a particular pet, but I had to do it with mine. And once I realized that my dachshund could no longer function the way she had been able to even a week before, I couldn't understand any reason, and notwithstanding that we had insurance, that we could have done something, was there a reason to do that, or should she, in this particular case, have had the right to pass with dignity without a lot of suffering?
Right.
And we do it for our pets, but yet we have not gotten to that place and time where we can recognize that. And I think
Are there other countries like Europe that?
Oh, yes.
the Netherlands does it, but here, and they're just changing now for dementia. But in the Netherlands, if you are cognitively capable but have a terminal illness, like Duchenne's muscular sclerosis, muscular dystrophy, because this was an example that I had read about the other day. And this young man was 39. He knows he has a limited time left. He said, I have gotten to be age 39, making all of the decisions for me, about me. I have lived my life in accordance with how I would like to. And now, here I am, faced with this particular situation. And I can do nothing about it other than to take my life in my hands. And maybe I want to go a little more to the edge of when that disease appears, but what happens if I'm not cognitive and can pull my own trigger or swallow my own pills? And so to go back, in the Netherlands, if you have cognitive capability, you go before a judge and you say, I wish to terminate my life because I have thus and so. And if you come back 31 days later and you repeat the request, and nothing has changed in the sense of the court's understanding or the medical profession, et cetera, and the medical profession has to remain neutral. They can't have an ethical perspective. They just have to have a clinical perspective that this is a terminal illness. And if you ask for the second time that you want it to happen, then assisted suicide, euthanasia, whatever you want to call it, is afforded to you. And very recently, they have upped the ante a little bit, so to speak, to determine whether or not somebody who cognitively can't speak for themselves, and this was the Barry issue, all right? Even though our documents aren't written with a dementia exception, there are many, and next week I have Scott Solkoff on to discuss exactly this kind of a situation. Is there a but-if clause in that, you know, I have a terminal illness, I don't want anything affirmatively done, but yet you can't terminate it? Can you then say, but if I have dementia and I am no longer capable, I now allow my surrogate to say the same thing? And I think we get into some very, very murky water. Is it homicide? Is it assisted suicide? And these were a lot of the Kevorkian issues that went on a number of years ago, and it's been going on ever since Socrates and the hemlock juice in the ear and the Hemlock Society. And, you know, many people will say, if you want to do yourself in, you can without going through a lot of agony. I mean, it takes 4 or 5 helium balloons, if that's, you know, what you so intend to do, inhaling them. All right, after you sound like Mickey Mouse, then you expire. But I mean, we do have the ability to take our future, our life, in our own hands, and we read about it every day. Now, many of those situations, like the one we just observed with the young man that had a very awkward social life and decided that he would go on out and kill as many people, especially females who rejected him, who we didn't even know, and put it all over the internet. But yet he still carried out his miserableness, all right, but wanted to do it in a way that somehow or other in 2014, whether it's the Boston Marathon or whatever it may be, do it where you take out the maximum number of unsuspecting and innocent people as a way to give yourself, I won't say 15 minutes, but your 5 minutes of fame, if that's what we want to call
He
it.
committed suicide, so he didn't even really,
Right.
he shot himself, so whatever fame he got, he wasn't
Well,
aware of.
and the fame was the notoriety of having killed others who, for no reason except gender.
It's a good argument not to use names, so not to promote the infamy, to use Murray's word. And I saw something on TV, maybe some of you saw it on Dateline or one of these shows, about someone who had committed murders in a school in Ohio, I think.
Mhm.
And a coach was the hero there. Did anyone see that?
Yes.
And NBC said that if we will not, on the request of the school, we will not use his name or show his image, because the story is not really about him, and we don't want to give him any of what he wanted. The man, the boy, not a man, a boy, was caught alive and is facing charges. but it was more about this coach who was the hero and chased him out of the school and
Right.
saved lives.
And unfortunately, we live in a world of paparazzi, sound bites. I know, just like you do, the minute there is some catastrophe somewhere, the Palm Beach Post sends me an
Yeah,
alert,
me too.
you know, there's been a horrible accident, you know, 7 people died when a bridge collapsed, or whatever it may be. And society has always been vicarious in terms of looking to see the suffering or the sensationalism of others. Now that we have a media that allows us to do it in nanoseconds, it's very difficult to put that kind of a firewall up, if you will, to say we're not going to allow the name or the, you know, the image, as it were, to be utilized. Do not give him his X worth of fame. But somewhere in that food chain, somebody is going to do that. And-
Probably TMZ.
All right, well, whatever it may be. Roberta, you had a question?
I wanted to get back to what you were saying about Scott and the advanced directives. When my husband was dying in hospice and the kids got down here, thank God I had those advanced directives, because one of my children made a statement, because that, why are we starving him to death? And you couldn't get food into my husband, he wasn't taking it. We were trying to get fluids, we couldn't get fluids in. They did not take any heroic measures. There were no injections, no IV, no tubes or anything else. And my child said to me, I don't want to die. It looks like you're starving to death. I don't want to die this way. My response was, make sure your spouse knows what you want and put it in writing. You saw these advanced directives before we ever got to this point. You were there when they were written. You were sitting in the lawyer's office with us. So I mean.
But we never think about the practical
But
implementation.
that's how important the advanced directives are. He
I
could
went
afford it.
through the same thing for 10 days. No food, no water, nothing, because it was the best thing for him, considering his situation, and there was no problem.
And the other thing that you need to recognize, that in the process of the body shutting down, when you stop drinking and you stop eating, you do not feel hunger and you do not feel thirst. It's one of the unique contributions that our body and our brain do, because as we start to shut down the peripheral things and keep our brain alive in order to have the autonomic functions like still being able to breathe or whatever it may be. But this is a question that's constantly asked, and it has been the considered opinion of doctors, philosophers, especially in hospice, that once the process of you refusing to eat, as long as it's not a protest at Guantanamo Bay, but I mean in the normal process of a body shutting down, there is no thirst and there is no hunger. And when we saw what went on with Terry Schiavo at the end, you know, with the T-shirts, I'll go in and give her a drink of water. Well, A, she couldn't drink, and B, they sensationalized something that at that particular point in time should have been kept
Private.
amongst family and
Personalized.
amongst the professionals who were doing it. And so I think that part of understanding, and what hospice does well in the end of life sequence, is to raise issues like that and comfort the family that what they think may be happening is in fact happening. Yes, he's not drinking, he's not eating, but he's not suffering. And I think if that were better understood, then people would not, such as what went on with your son. And you also raised another important point. We sign documents, lawyers explain them to us, and we think of them in the abstract. Oh, that's not gonna happen. Or, I remember, you know, my dad, he had them, but I mean, it's remote, and especially if you're under a certain age where you're still kind of infallible, or you don't see fallibility coming up anytime soon, to say, all right, well, I did it, I protected myself, but when the time comes, you know, do I have the ability to call an audible? And it's not so much that you haven't set your course in place. It's typically children and other family members who say, oh, Fred would have never wanted that. Well, Fred said he did. And this was no different than what I had to go through 8 weeks ago when my uncle died, and it was do not resuscitate, do not intubate, and the intensivist at the hospital wanted to do just that. And we had to remind him that this is my uncle's wishes, we're merely the surrogates enforcing it, and you need to listen, because that's why they're there. And not for you to say, what if? Because I asked him at the time, and I know I may be repeating myself, I said, aren't we going to see the same situation in 2 to 3 weeks? Even if you kind of put a Band-Aid on the problem for now? And he couldn't say no. He said, more than likely. I said, so then why are we putting him through this when he specifically said, when he was cognitive and capable, I don't want this. It's not for us to call an audible. And that's what happens. I see it a lot in elder care mediation. When the kids come down and challenge mom's decision, and they don't understand exactly what it is that those documents say. And it's very important. One cannot express it, even though it's a difficult situation, that when they're written, and when they're in place, and when they've been executed, to sit with family members and say, look, here's what I've done if the situation gets to this, and I don't want to put you through the agony without them, of trying to decide what I would or would not have wanted. I'm putting it in writing, it's legally binding, and if anybody has an issue, let's talk about it now, because it certainly is not a bedside discussion when these things are going on. And I think that many families, like in the old days, if you wrote a will, you were absolutely sure to die. I think it's a very tender subject, but gets very high visibility at a time when it's happening and those documents need to be used rather. Rob?
My father-in-law had said to me, I don't want tubes. He didn't have it in writing, but he turned to me whenever he was sick, and he had several heart attacks and lived in our house for a few weeks at a time. And he did say that. But the day that he was dying, my brother-in-law lives in Miami, and he said, keep him alive, I want to see him.
Oh.
And so we did have him with the tubes. I still feel guilty to this day, because I know he didn't want to die that way.
Mm-hmm.
But he did die that night, but he did also see the sun, and he knew who he was. So, you know, it's a very difficult
Yes, it is.
decision to make.
And when I've had discussions like that, and invariably it may be an out-of-town daughter, son, you know, close family member, and they say, well, you're killing Dad. And you have to remind them, A, this isn't about you, it's about Dad. And if what you're saying on the phone is that you need 24 hours to atone,
Yeah.
then get thee on the next plane and get down here and do what you have to do. But do not stop the course of events that your
Yeah.
father, just to use that, has put in place for exactly this situation. He doesn't want you to have to second guess, nor does he want you to override what he's done. So hopefully we will be able to keep him
That's why he
to
has
the
to be
point where you
ready.
can see him, yes, and get
Luckily,
moving.
it was only an hour,
Yeah.
you know, between the time that he called
Okay,
and
well,
God
that was
to
good.
us.
1 second. Muriel, did you have?
And I just wanted to say that when I was in that situation, I'm fortunate that it went very smoothly. Marty's second marriage, Marty's kids all knew about the, you know, the
Advanced,
living will
right.
and the wishes that we had. Nobody argued the point. When I had been away for a few days, when I came back, I saw that there was a very sudden and drastic change. And by the next day, he wasn't eating and he wasn't drinking at all. And when the staff came in, they said, we can't get him to eat or drink anything. And the first thing I said was, no intravenous. These were his wishes, and we have it in writing, and this is what we want, and this is what he wanted, and so on and so forth. And I must say that it was very peaceful. They told me that without fluids, he would last generally 5 to 7 days, and on the 6th day, he died. It had gotten to the point where every day I was waiting for the phone to ring and saying, what's taking so long? Because it was just prolonging the agony.
Well, that's why they didn't say 5, they specifically 7.
But, you know,
But-
ultimately, it was a relief, and fortunately, nobody gave me a hard time. My daughter came down and stayed
And we
with
can
me.
go without food for a couple of weeks.
Yeah,
We
but not
can
with
go
food.
without water for
They
a
said
period
5
of
to
time. We
7
can go
days.
without air for about 3 minutes, if we're real lucky. Hold on just a second.
I don't know if it's appropriate right now, but I have a friend who's going through something. What is the difference between Vita Care and Hospice?
Same.
Vitas?
Vitas.
Vitas is a provider of hospice care, just like Hospice by the Sea, Hospice of the Palm Beaches.
It's a brand name.
It's, right, it's like saying dementia, and underneath it is Alzheimer's,
But do they
Parkinson's.
have to be dying?
No,
Uh,
my son was
the-
in
I
the-
heard it's
Florida.
palliative care.
Palliative care.
We're starting to get into kind of a funny, fuzzy area. Palliative care, all right, is really what hospice does. It's kind of allowing you the dignity and whatever capability that you have at end of life to do it in a dignified and a pain-free way. And normally, it's triggered by a doctor writing that he believes that the patient, within the next 6 months, will succumb to a terminal illness. And since he doesn't have an exact calendar either, typically there are 2 6-month extensions that you can get to. However, palliative care, which is allowing somebody to do the best they can to thrive prior to entering, you know, it's almost like end of life, even though you can't figure out, you know, exactly where the boundary is, but there's a time before that the patient may not want or have to come off of, let's say they're on some experimental drug that may help to cure their cancer, but yet they need the benefit of an environment that still will allow them to thrive and to be pain-free. And many times, hospice can provide that, but it isn't necessarily that they're going to come in and take them off of the cancer medication or some of the other things that they're doing. They're merely going to allow the setting to be a better setting to allow whatever the medication or whatever is going on to work, whether that's in a physical location that's calm and quiet, that includes massage, that includes, you know, spirituality, not necessarily religion, but to allow that individual to have the greatest ability to allow the medication or whatever else is going on to still possibly work before they've kind of crossed over that borderline and now they're on a terminal path.
I have a friend whose husband is 90. I don't know if this is appropriate right now, I'll make it quick. He needs a new hip.
Okay,
They will not operate on him because he has stage 4 kidney problems, he has pulmonary problems, he has a pacemaker. No anesthesiologist will put him under.
Probably wouldn't
No.
survive it.
He won't survive it. He
Right.
would like to do it
Right.
because he is in such pain now that they keep giving him painkillers which don't help. And now he's gotten a hematoma and he's in the hospital.
right,
And so someone said to her, you should have,
at hospice,
yeah, but is he eligible for that?
absolutely. If you have stage 4 lung cancer,
You know, this is
Kidney
kidney
failure.
failure.
okay,
Anything.
Stage
four.
stage 4 anything is a stage out of town.
Yeah.
All right, and so that probably with his combined conditions,
He's always in pain.
Right.
Excruciating
then
pain.
what hospice will do when they step in, they will do something, you know, the hospital's been giving him their equivalent of Demerol, OxyContin. They will
OxyContin.
give him a therapeutic level from a pain perspective of morphine or whatever else is required, so that he is pain-free and calm, and that whatever illnesses and whatever the cancer or the pulmonary, and obviously, he may want it because, but there is no doctor or surgeon that will go in and do surgery where
He's
the
been
risk.
to 4 different doctors in 2
Right, where the
different states.
risk and the benefit, in other words, the benefit does not outweigh the fact that he will be dead. So
Yeah,
going
or stroke.
through, forget even the expense, but probably in prepping him and getting ready would be too much for him to go through. So they're much better off moving towards, you
Hold
know,
on.
what hospice has to offer and raising that level of painkiller and whatever else they do in the right environment, not necessarily in a hospital bed.
Is he aware?
Yes, his mind is as sharp as could be. I mean, that's the sad part.
Does he know the alternatives?
Yes, and at this point, he's in so much pain that he says, just put me under. I don't care, I want to die,
Yes.
because I can't stand the pain anymore.
Well, and see, now we're back to the earlier discussion,
Yes.
all right? Why should yes, we have hospice as a mechanism to allow us to move to end of life in a pain-free manner and in a dignified manner. But why should this man be begging to be pain-free and recognizing that he probably doesn't want, and the only reason that he's asking for the hip replacement and it wouldn't have anything beneficial because he'll never be up on it to walk again, then why shouldn't they maximize the amount of painkiller even if it happens to do him in? Because with his pulmonary and the rest of it, as you take in more and more morphine, it deadens your automatic reflexes. And so it eventually stops your breathing if you get enough of it. And that's what this man deserves, to be laying on a table and suffering because of the Hippocratic oath, do no harm, which we understand, and do not hasten death, which gets to be more and more complicated when you see a situation like this. And I thank you for raising that point, because it fits right in with exactly what this discussion was. And, you know, not to be trite, our pet would have been allowed an exit program long before this.
Yeah, he's pleading, he says, put me under, I hope I go.
One question,
Yeah.
does he have any advance directives?
Even if he did, Betty, this is
I
the
don't know.
Barry argument. There is nothing in the advance directive which says, and the advance directive says, if I can't, my surrogate shall, or even if I'm here, take no measures which would extend my life, all right, including tubes, breathing, food, whatever it may be. But nowhere does an advance directive turn around and allow us to say, and if I'm like that, and I'm in intractable pain, please put me out of my misery. Because that would be an assisted suicide, euthanasia, and our Judeo-Christian and our legal system would view that as somebody helping somebody die, regardless of how the circumstances of the person asking may
If you
be.
have a living will.
The living will
Doesn't-
only says you can go to my safety deposit box, you know, and you can call the shots for me within the bounds of this. There is no living will, and that's what I was alluding to. You know, whether it's we do not have in this country states right now that have permission to allow us, even though for 90 years he's called most of the shots as to how his life was led. We don't have much choice as to how we die. And that's a very unfortunate set of circumstances in an aging world where these things are going to be happening much more frequently and happening to a great degree at home, because we don't have enough hospital beds, enough nursing home beds, enough assisted living beds. You know, you've heard me say, if we add them all up, it wouldn't take care of a third of the Alzheimer's population.
There is something in the living will or in the advanced directives that says whatever medication is necessary to relieve pain.
Mhm.
So the only out there is him getting medication to relieve his pain.
Right.
And
They
it may
won't give
shorten
him-
his
Right,
life.
and there you draw a fine line. And that's why the system has hospice, because they kind of fall under what you'd call a Good Samaritan law.
Yeah, They
That-
won't give, they won't give him they will only give him oxycodone. Like I had a prescription for Nucynta, and they wouldn't give him that because it would affect the kidneys. So the doctors won't provide anything stronger than the
Well,
oxycodone.
then
Try
there's,
hospice.
right,
Should go to hospice.
then it's time absolutely for hospice. Because they are not laboring under those restrictions, because they don't really care. The palliative care doctor, the hospice doctor, is not concerned about the medical affliction, simply that he is terminal and that it's up to them to keep him pain-free, comfortable, and as dignified as possible. And so this is a big distinction. And I would have thought by now, notwithstanding the fact that the medical profession, the clinical medical profession is always trying to do something, all right, that they would not have called in hospice.
They haven't.
Have they called Vitas?
No,
Oh.
a friend of mine who works for the Alzheimer's Association said he should be in Vitas.
Yes, that's
Right.
what
He should be.
Well, he
no
should be in
doctor.
hospice, and if Vitas is who you want, or Hospice by the Sea, or any
But I
hospice.
mean, nobody has suggested
We
hospice.
did
Well,
that.
it's time for you to.
I
did.
called hospice when I called Vitas when the doctors did not suggest it, 2 weeks before my husband passed away, because the people who were taking care of him did not think he was at that stage. Obviously, I was right and they were wrong.
Right.
So the caregiver who is dealing with this person should make a phone call, and they can work through the backdoor channels to get your.
And it
Somebody
isn't
should
even
suggest
backdoor.
it.
Well-
Once you invoke hospice, and I cannot imagine a doctor who says this patient has stage 4 kidney cancer would not indicate to somebody that this is a terminal illness because we can't operate, we can't radiate, and he's too frail, too fragile because of all the other things to do anything.
They've sent him to a hip doctor who gave him a shot, which
Oh,
didn't work.
And see, this is where I think the medical profession should be taken to task.
And-
Because
Or the
because if the
caregiver may
strong,
not be ready to
I'm
accept it.
sorry, because if the strongest thing they could give him at the hospital was no different than what the orthopedist would be able to do in his office, then I think they not only went on a fool's errand, but they disrupted him to the point where it probably aggravated.
He's now in the hospital because he was in such pain that his wife took him. He has a hematoma, a huge one behind his knee. They are now filling him full of blood transfusions, plasma, all of this stuff.
See, and this is running not only the Medicare clock, but is so unnecessary, because the man wants out, and if the hematoma were to break loose and he'd have a stroke already or a heart attack and put him out of his misery.
David,
But wait a minute,
but
wait,
it's
wait.
probably the caregiver that can't accept.
Well, no, she doesn't know what to do.
But
it's not only that,
That's
All
why
right,
I'm asking.
I want to hit
Somebody's
this from Yesling.
Let's take worst case scenario. He has the surgery and he survives.
He can't
Wait,
have
wait,
it.
wait,
Wait,
let's
wait.
say he does. Now you open up a whole new set of problems. He can't just lie there out of pain. He's gonna have pain from surgery. He's gonna have to do rehab.
Which you can't
He
do.
can't have surgery under any circumstances, even if he survives it, because then it starts all over again, the pain. He can't do that.
And one of the things that the doctors are avoiding right now is something called medical malpractice liability. And so they are going through the motions of doing everything that they, as doctors and surgeons, can do. And they are not really thinking about the person as a human being with dignity, caught up in an end-of-life situation that to him personally is intolerable. To have sent him out to a hip surgeon and put him back into the hospital and gain nothing from it, when you leave here today, you call your friend, and to the extent that you have any influence, say, the wisdom warriors all discussed it, and many of you have been there. that it would be intolerable not to call in hospice, and they don't need the doctor to do it. Simply say, I want hospice to evaluate them, and if the hospice doctor says, yes, this is a perfect candidate for us to put him out of his pain and allow him a dignified exit, they'll get it done. The doctors are looking to get off the hook in one way or the other, but they're running
So she just calls like Hospice by the Sea?
Yeah,
or
call them.
Well, that's
Del-
cool. What hospital is he in?
Delray.
Okay.
They have their own
They have
hospital.
their own
They have
hospital.
hospice right at Pinecrest,
That's where my wife went
and
to
they'll
hospice.
wheel them over
Yeah,
there.
because she doesn't know what to do.
And the
She's
fact that they
back.
haven't done it is
They
unconscionable.
want to send him home with therapy at home.
Oh, my God.
Right now, they're wrapping his
Well,
leg.
the one thing that that this
They're
woman must do
experimenting.
is absolutely use what's called spousal refusal. I cannot have this under my roof, I will not tolerate it, it will amount to nothing, I want hospice, now.
His doctor
Don't,
can make arrangements, right?
yeah,
His
of
doctor
course.
can do it.
Nobody
She doesn't have to do it.
Well, then her general practitioner should do everyone a favor and call in hospice
Now
for
you know,
evaluation.
now you know,
Now you
you can
Of
give
course.
this,
Doesn't have to
you
call.
can give this advice or suggestion, call it what you will, to your friend.
Right,
Is
and
she
you
a
know what?
Close
Yes,
friend.
very close.
And
Have got
at the
to
same
do
time,
this.
I'll give you the number before you leave.
Okay,
For hospice, it'll be Vitas, but
that's,
what do you care?
yeah.
All right, and then they will move, and Pinecrest has its own hospice. I had a couple of very good friends of mine
My wife was there.
that went
She
there.
says, I don't know what I'm gonna do if I take him home. He can't
She
walk.
is not
He
taking
can't
him
get
home.
You
That
has to
would-
refuse.
Maxine, I think you got the answer.
You've got all the
Right.
suggestions
Right.
necessary, you
Right.
don't
I
even have
mean,
to repeat it now, because we
Right,
know.
this is akin to torture. You know, we
Right.
talk about giving somebody who's been accused of murder the wrong injection because they might suffer, and how unconscionable is that, you know, and it's against, you know, the Constitution. So is this.
Doctor told me and my daughters who were present at the time, when my wife was at Delray, that she's in a position right now where she should be in hospice. That's what he told her. She should be in hospice. And I spoke to my daughters and I decided, yes, I agree, she should be in hospice. She was in pain. And they put her into hospice. And as David said, they gave her morphine, they gave her Ativan,
Whatever it took.
whatever it is, no question about it. And she passed after 10 days in hospice. But she was no longer in pain. One thing we didn't know, that when she died, I thought it was complications with the Parkinson's. It was not Parkinson's that killed her. She had cancer. And nobody, our doctor who she went to see, our internist who she went to see constantly, I find fault with him, because he should have referred her to the proper physician to find out what, if she does have cancer, and whether it's through x-rays or what have you. But the fact of the matter is, hospice took damn good care of her. She was in no pain when they had her there. They saw to it that she had no pain. She lasted, as I say, a short time. There were 10 days, which is not a long time. And that's it. But hospice is fantastic.
Another wonderful thing about hospice, aside from the medical care, is they had a non-sectarian chaplain
Yes.
that came to the room. He spoke with Marty as much as Marty, and Marty communicated actually to the end. He was capable of speech, and he spoke to Marty, and Marty listened, and he came and he spoke to me. And I felt very comforted by him, because it wasn't a religious thing, it was just a person-to-person thing. And then when I had the memorial for Marty, I asked him to come, if he would come and speak at the memorial. And first, he told me that he couldn't, he had a very important meeting that same morning, and he had a conflict, and I'm so sorry, I'd love to be there, but the day before I get a text from him, I managed to make arrangements, I'll be at the memorial. And I was like, whoa. He changed whatever it was in his schedule to come to the memorial, which I found extremely comforting. Because I don't have my own personal rabbi or anything, I don't really have religious affiliations. But just having this human person who is caring and loving and give you a warm hug.
That's the spirituality of it, as
Yeah.
opposed to the
Wonderful.
religion.
Yeah, it was
of it.
great.
They have to
David.
do a fantastic job.
Yes, they
David, I have a corollary
Yes.
issue. My husband has OCD, has
Obsessive compulsive
Compulsive
disorder,
disorder.
just for the audience.
psychiatric problems all his life. His sister also had agoraphobia, which is the fear of leaving our house, a psychiatric problem. And I really think that his body should be donated to science, to see how much is genetic, how much is what they can find. And when Muriel had told me about it and gave me the information, I asked my son. And especially after 2 weeks, you said something about we don't ask our children's permission to go on with our lives, but I did. And he
Well,
said.
this wasn't to go on with your
No,
life, it was
yeah.
how you were going to
I
treat
asked
your
the
husband at
children,
it.
yeah.
And my son, who was not at all religious and has no intention of making a bar mitzvah for either son, said Daddy was raised as a religious Jew and lived his life as a Jew, and he would not like this. And therefore, his opinion was I shouldn't do it. So I didn't proceed, but I'm having second thoughts about it.
I want to, first of all, thank you. Our hour is up, and I want to thank ManorCare for offering us the facility today. And I think we had a very, very informative discussion, one that I think our listeners and our audience will really benefit from, because people do not hear these kinds of conversations. You are affording the rest of the world such a unique opportunity to listen to your insights and how you see what you've gone through without tainting it one way or the other, either by way of religion, personal prejudices, etc. And you speak from the heart, and you speak from the things that you are going through. And that makes such a difference that for anybody listening, they have to come away with a greater amount of knowledge about things, even this last discussion that we've had about when to call in hospice and the futility of what this gentleman is going through. So I want to thank you, and what more can I say to our audience, but this is the kind of information that you need no matter where you are, whether it's here in this country, around the world. Everybody is faced with these issues at the end of life, and in an aging society, we will be seeing more and more of these conflicts come to the fore, and documentation alone cannot resolve all of these issues. So stay tuned.
Okay.
Now,